Well, first of all, I want to welcome everybody and thank you to the panel members and the observers for being here and taking time for this. The purpose of this dialogue is to discuss choice and services in the community behavioral health system. Different perspectives and questions on this topic will be shared among the panelists. This is not a forum for complaints, but it is a forum for coming together. The observers will be only in the observer mode. They won't see each other. We all see the panelists unless you turn your camera off and then you disappear. So the only people interacting really with each other is going to be the panelists. I want to introduce the moderators first. I'm Lori Vergeer. I chair the Northern Arizona Peer and Family Coalition, and next to me is Kathy Basher, president of the Arizona Peer and Family Coalition. We have Christina Sabetta and Candy Blakesley doing the background technological stuff for us. I just wanted to give them oodles of credit because that stuff is all way beyond me. So I want to mention, as I introduced the panelists, that we did have a change in the list that went out. Tricia Reiner had a situation come up. She could not be here. She's with Family Involvement Center. So at the last minute, Jane agreed.
Close enough. Yeah. Yeah. Very happy to be here. Thank you.
Thank you, Jane. And Jane runs the Family Involvement Center based out of Phoenix. So we have, and I'll just run through everybody's name. We have Susan Kennard, the Access OIFA Bureau Chief, and Troy Grover, along with Sherilyn Horowitz, and Peer and Family members, also Peer and Family member Cricket Barrientos. Thank you, Cricket, and Ann Romo. Thank you, Ann. And we're hoping Dina Ross will show up. I don't.
She is actually here. For having camera issues, so we'll be able to hear her, but we will not be able to see her until she gets the camera.
Okay, well, thank you, Dina. Dina, do you want to say hi so we know that we can hear you?
Hi, yes, yes. My name is Dina, and I'm the president of Nami Flagstaff, and I'm a peer and a family member. So thank you so much for having me.
Okay, we're so glad you're here. Deb Jorgensen, OIFA manager with Care First. And Deb has sunglasses on. Evidently, Deb scratched her eye and she's protecting herself from too much light. We're hoping Dee Redding will join us from Care First. She's the director of medical management, but she is not on yet. Veronica Welch, OIFA administrator for Blue Cross Blue Shield Arizona. Glad you're here, Veronica. Erin Benjamin, OIFA child and family member liaison with United Healthcare. Welcome, Erin. Sean Hatch, Regional Vice President of the Northern aspect of Spectrum Healthcare. Thank you, Sean. Trevor Davis, Chief Clinical Officer of the Guidance Center up in Flagstaff. Welcome. Tamara Player, CEO of Polara Health. Thank you for being here. Chris Gonzalez, CEO for Hope Lives. All right, Chris. Greg Billy, CEO with NASCARE. All right, great. Dan Haley, CEO of Hope Incorporated. Thank you, Dan. Daniel Davidson, co-owner of HiBad Behavioral Services. Welcome, Dan. And the Honorable Mayor Paul Deasy, Flagstaff City Mayor. Thank you for being here. And I hope I didn't miss anybody. So this is our panel, and Kathy's going to say a little bit about the Arizona Dialogue. Have at it, Kathy.
Okay, welcome everyone. I see some faces I haven't seen a long time, and they've grown older, have actual beards and whatnot sprouting here and there. So it's so good to see you. Many of you guys have participated in dialogues. We've been doing these for over 15 years. We've done over 100 in the state of Arizona, and we have definitely affected change because of the dialogue process. Today, we're going to be talking about choice. And for many of us, it has been a difficult subject. It has been painful. Our community has been very divided on this, But today we're going to talk about choice in a sense of how we feel and how, as leaders, you've been impacted either by choice or by providers by not being able to give choice, and also your concerns for the future, the stress on your agency, and what you see might happen as we move forward. So again, this isn't about attacking anyone. This is about us as a community sharing our feelings, and the end result is really finding a way that we can work together to make sure that choice happens up in Northern Arizona. And so I'm just gonna, you guys all know the issues about choice, and this is a dialogue. We're not gonna interfere unless there's absolute silence for quite some time. And so usually we don't have to interfere as moderators. So I'm just gonna just throw it out. We're talking about choice in Northern Arizona and the struggles that we've had and our feelings about that. So I'm just going to open it up, and if I don't get anywhere, I'm going to pick on someone. So I'm sure that everyone is very well acquainted with this topic. Okay, so we're talking about choice today. So Trevor, since you and I have been gone and parted for so many years, you know that this is part of recovery and the struggles as a community. Would you like to start with this topic?
Sure. So thank you for that, Kathy. I've been in the Northern Arizona system for 20 years this year, worked for a couple of different health homes, as well as the Regional Behavioral Health Authority and Access Health, one of the Access Health plans there. And at the provider level, I think one of the things that we often see is that the health home model that's existed in Northern Arizona for decades works for a good chunk of folks and doesn't work for a good chunk of folks. And so it has been challenging at times, given payment models, given referral processes, given quality standards, that as a provider, it has been very difficult to get out from under the red tape in order to provide what we know is best for the folks that we're trying to serve. And so I think we have struggled at times to get referrals out. We then have to follow processes and all of that. And I think the drive is there among the people within these organizations and within the providers to make it work, to figure out a way for it to all come together and for people to just get what they need to get. Because I think the one reality is that the demand is far beyond the capabilities of the entire network combined. And so we need everybody pitching in to support one another, or we're letting our communities down. And so I think that's always been a good chunk of the struggle. So I have personally been extremely frustrated at different times by just processes around paperwork. I think all of us here probably feel very much that the paper should follow the person's needs rather than the other way around. And it seems like the system often gets that backwards, unfortunately. And I get from a cost containment perspective, you really need both, but I wished it were different in so many ways. And I think it's just been an ongoing battle getting referrals out. Agencies have turnover. We have struggles with staffing at times, but we still all want to work together. And I think now more than ever, especially in Northern Arizona, we're getting opportunities as there's an upcoming REBA change and other things going on, that we may have some fresh opportunities coming up that maybe haven't always existed in the past. And so I'm not saying whether I support or don't the change, but I do feel like it's a big change. And I think that the system will see some improvements, some additional new challenges as well. But I think the exploration that a lot of providers are scrambling to do right now is to find ways to break down all of our bureaucratic barriers and get to work and get helping people to get what they need, because we all need to pitch in.
Yeah, I just want to jump in really quick. This is Tamara. Building off what you said, Trevor, is, there's no perfect model, whether it's the health home model or fee for service or whatever, but the value of patient-centered care needs to be there and be driving, right, what we do. And I think sometimes with the challenge that we have with all of healthcare right now, what often drives that are the all the administrative burden, all the processes and the referrals and all the things that get in the way of doing what we are all committed to do. And so even if we, even with the REBA change as a system, unless we're really addressing those processes that get in the way of really patient-centered care, I don't know that it's going to change, because I've worked in other systems that are, similar to where we're heading, and the same challenges are there. What we know works is integrated care, team-based care. And so, the challenge at times is how do we do that, and how do we coordinate care in a way that really focuses on that patient-centered care without letting all those bureaucratic procedures get in the way, because that's what everyone wants to do, right? Like I know that's what motivates our staff to do the work that they do. So anyways, I just wanted to build off what you said, Trevor, because I do think we have to have that value of patient-centered care, or it doesn't matter. Yeah.
Hi, this is Christopher Gonzalez with Hope Lives. So I couldn't have said it any better than you did, Trevor. And just echoing again from Tamara and Trevor, we see a lot of partnerships in the community collaborating together that we haven't seen in years or ever, between those intersecting of various health provider types, as well as the health plans working together in more collaborative ways as well. So, that's something that I think that the community can be very proud of in those changes that we're making to ensure that we have voice and choice for our membership. But again, I can't say it any better about the bureaucracy and the red tape. We got a lot of innovation going on in the system, but somehow we're not really balancing that teeter-totter of the political bureaucracy, red tape aspect to what really needs to happen to put that person centered first. But I think we are getting creative in some of those workarounds. However, when it comes even to the end of that workaround, there's still some of that red tape. And so I think that that's where we need to address it. Ultimately, I'm thinking, Kathy, when you first made the introduction, who is it impacting? Yes, I think that it does impact the providers and the health plans, but not to the extent that it really impacts the person. It's impacting the community. That's who we're here to serve and to provide these health and wellness, mental and physical opportunities for, to integrate fully into our community. And, so I have to put the agency aside, and it really hurts the person.
Well, thank you. I'll jump in here then. Thank you for all the prior commentators. I just want to add in the really the culturally compassionate care aspect of this, which the bureaucracy really is tailored towards a very Western civilization institutional approach. Here in Flagstaff, I'll just say that as an organization, the city of Flagstaff, what we're really trying to do is divert individuals away from the criminal justice system. We've created a new program over the last year that will be operational in April, where 911 calls will be responded to by a behavioral health specialist and a fire EMT in a van, rather than having the police having to be involved necessarily unless it is a violent situation, in which case still the behavioral health specialist is expected to take the lead in certain circumstances. So we all serve different realms of populations, and just want to kind of focus in on what we're looking at as the city of Flagstaff. But in that regard, I'll say that 50% of all arrests in Flagstaff are Native American population. These are individuals that don't need to go, it's non-criminal in nature. They don't need to go through the criminal justice system. They don't need to go to jail. And we've recognized that as a council and as a city body. But the key here is that right now, 50%, 50, of all of the arrests in the city of Flagstaff are of Native American individuals, despite making up about 9 to 10% of our population. With those numbers in mind, many of these individuals, they're not asking for counselors, they're asking for medicine people. They're not certainly not asking for the police. They're asking for people who can understand their quest to, attain Hojo and move forward in a culturally competent manner. And so I appreciate the discussion about the bureaucracy. Just know also that the bureaucracy affects the many individuals because it is a very Western centralized approach that honestly we have to follow based on the laws and everything else. But it is extremely important to know what population we are aiming to serve and ensuring that the services we're providing, the labor, the resources are all tailored towards those individuals. And yes, just want to point that out.
So I just want to comment a little thing, Paul. We have block grant funds, and I was hoping Dan Haley would step up to the plate on this, specifically for Native Americans to get these kinds of services, and they have not been utilized. And so that right there is an example of choice.
So this is Anne. I am a family member of someone who's been involved in getting services for like maybe 6 years now. And I just wanted to say there is another underserved population, and that is individuals on the spectrum with an SMI diagnosis or just behavioral health issues, which tend to occur with that disorder. It's been very hard to get specialized care. Sometimes I've been successful to get some, but you have to really work through all the rules. I don't know if it's bureaucracy in the background or just there's some other issue going on. Keeping everything in the health home restricts the care and prolongs the involvement of the individual. So I just wanted to say that about people on the spectrum are underserved in the North, except for those lucky enough to get through to something, fight their way through, or just happen upon something that's available. Thank you.
This is Greg. I think, easing the red tape, which I think has been in progress with, referrals and the whole process of getting people into services with various providers is important. And it seems like we're heading that direction to make that a little easier, because we obviously don't want to have delays in getting people to where they want to go. And then when they get into a provider where they can get help, of course, everyone works together to try to get them the full spectrum of care that they need. So I do think that's really important, is easing that, the bureaucracy of choice, so it can be person-centered for people who want to have choice. And I think it's important in the community is because there's so many people in need, as was already mentioned, that for providers, we have to be able to do that because we want to be viable, be able to, stay functioning as an organization and be able to provide services. And dealing with, choice and being able to serve people easier actually affects, an ability of an organization to function, to be around and serve people. Because as we know, everyone has different needs on the spectrum. I mean, their needs may be greater today or less today. And a provider, they may use different providers at different areas of their care. And we don't want to lose certain providers because of too much red tape or bureaucracy, or how the system operates. Because as we all know, encounters, and there's factors that are bottom line looked at to keep an organization viable and going. So I guess the stressors, and just talking about, I think, why choice is very important, and making it easier for that choice.
And if I can piggyback, I'm a mom of autism, but I'm also, we have a nonprofit organization, and we serve families, community responders, and educational leaders. And the reason that I designed it that way, and you can see the stitching behind me on all the different puzzle pieces, is because there are so many gaps in raising a child. And to be honest, I grew up with Christian values. So for me to apply to get long-term care for my son, I have to tell stories. And those stories are things that go against my religious belief. So many of our families fail to play the game. And because of that, the end result that we're dealing with today is death. And that's on all of our watches. So I hear everything that you're saying, and I'm so grateful that you bring up the truth. But all of you have the knowledge I don't have, and I call it the power of influence. And when you do things in droves of people, change will occur, because people don't like to fail. And today we have to do it that way, because we're in a world right now that nobody cares about the populations that can't speak for themselves. We're trying to figure out our own issues as leaders. So we're the last people. And I have a 19-year-old, and he went through a very awesome school system until he got to the last year on graduation day. And when they have finally provided us, okay, we're going to all come together to talk about the next steps, and you have 32 parents that never engaged until that day, because the 12 years was already planned out for the majority. And now it's time to say, this is where you're going to go. And they don't have a solution. Everybody was going into one box. And we're working with a population, and there's many populations in the disabled community that go unnoticed and underserved. And we lose so many opportunities, so many educational things that we can learn about that community, but we choose not to do that because we fear things we don't know. So my voice, when I was asked to come here, was really just to say to all of you that keep fighting, because I'm telling you now, we will unify as a community. We are not going anywhere. Sounds of Autism will be around a long time, because I can't leave this earth until I know that my son has a plan. And right now, the plans that are being given to me by some of these leaders is absolutely unacceptable. I was in the business world a long time. I saw a lot of failures, but I also saw a lot of success. You got to work hard, and you got to be smart, and you got to care about other people, not just yourselves. That's very important, and you all understand that, and that's why I think you guys are great, and hopefully we can help support you as well. But thank you for letting me talk today.
This is Dee Rennie, and I just want to first of all test to make sure you guys can hear me okay. Wonderful, thank you. And I apologize, I was having some technology issues in the beginning, but I work with Care First. I'm the Director of Medical Management, so I know we've been talking a lot about the barriers that we encounter, but I just wanted to share from Care First. I oversee the care management team and care coordinators, which they're non-clinical, but they do a lot of work to support and serve our members. So some of the things that we do is working with our highest risk population, complex needs members, and helping them navigate the healthcare system, because it is complex, right? And it is very individualized on what your specific needs are. And there are a lot of different barriers. So I just wanted to communicate and share our continued commitment to our partnership with our behavioral health providers in the North, and then the community that our care managers work very hard to remove those barriers and work through the red tape and help, the member get connected to the services that they so greatly need. And that covers the gamut of members who have been diagnosed with autism. Members who maybe have an SMI, might be SMI eligible and could be recipients of that additional services. Our Native American members as well in the North. So I just wanted to say it's not easy. I completely concur with a lot of the barriers and the challenges. And even on the health plan side, we see a lot of red tape. But I just wanted to let you know that our Care First care managers and our other department leaders here at Care First are very committed to helping our members and break down those barriers, build the relationships within the community, so that we're all aligned and we're serving and doing the best for our members. So thanks for letting me participate and be a part of the conversation, but I just wanted to share a little bit of background about some of what happens in the background that you don't always necessarily see or hear about. We can't touch every single member, but we have a lot of different methodologies with how members are referred in, or members can self-refer. We do a lot of reporting and data mining to help identify our highest risk members. So I just wanted to share that with you in case you didn't know. That is one of the things that the care management and Care First team does.
And this is Veronica. I'm with Health Choice Blue Cross Blue Shield. And first of all, I want to thank you guys for this conversation today. I think it's really important for us to be able to hear the concerns and the frustrations in a safe environment. And, I'll share briefly. I've been working in the behavioral health system up north for 24 years. And I want to be honest and say, I've come a long way, but I also want to really acknowledge the fact that there's a lot of feedback happening. I don't know if everyone's muted, but we have a long way to go. And so a couple of things that I want to say is, and again, I'm not here in defense of the health home model, because I really genuinely just want to hear what everyone has to say. I do know why the health home model was created. It was to prevent people from falling through the cracks. It was to really protect those individuals who didn't have family around them or a good social system to support them, especially in our rural and frontier communities. But I also know that we're not as rural as we used to be, right? We have more providers. We have a larger system. I 100% want to say we still need more providers. We still need a larger system. I think Trevor stated earlier that there's just not enough services for everyone to go around. And I wholeheartedly believe that. I also want you guys to know that I have worked at a provider. I've worked at the health plan and REBA. I've also received services myself and had family members on the adult side and the children's side. I will be very, very transparent in saying the bureaucracy and the politicalness and the red tape is absolutely there. I can't deny that. Just like stigma. Stigma is real and it is there. Is it going to change overnight? It is absolutely not, because a lot of those red tape issues were put into place to protect people. With that being said, not everyone needs all of that protection, and that protection may not be needed at the same level as it used to be. I like that we're having this conversation. I appreciate this dialogue. I think this has been a long time coming. I'm taking notes, not to put anyone on the spot, but I'm learning a lot from the information that's being shared. And I care about our members. I know our health plan does, our REBA does, Care First does. I work closely with Deb. We talk and we know that the system is not where it should be. It's not where it used to be. So I do want to take that moment to give some kudos to our providers and our community members and Kathy and Lori and Dan, who've been fighting the fight, right? It's not where it used to be, but we do have some ways to go. So thank you for letting me share. I'm learning a lot. I'm taking this information. It will be shared with our leadership. I think it's important to know the barriers that it causes, but I also think it's equally important to know why some of those steps are in place and how we can work together to keep the safety, to keep sure that our members are being taken care of. I don't want to see anything on the news about someone who's fallen through the cracks, not because of the legal issues, but because these are human beings. I'm one of those. My family is one of those. So let's keep this going. Let's keep this conversation going.
Hi, this is Christopher Gonzalez with Hope Lives. I just, as I'm listening to the conversation, it just reminded me of a few thought points that I just wanted to jump in and share. And thank you for bringing up earlier about family. I think sometimes when we get into our tunnel vision, we forget that the person is also a family. So I appreciate everybody that did bring up family as well, because it's not just impacting the person, but the whole family of choice for that person as well. Some other things that came to thought is that, and not to single out the red tape and bureaucracy as the only predictor or trigger to this, the barriers that we may be experiencing. But, Veronica, you brought up stigma and the health and wellness within the community. And I think, there's probably a lot of intersecting points, the barriers to informed choice and voice. So I'm glad that you brought that up, because that reminds me of remaining cognizant of the culture within the environment and within the community, as well as the stigma and bias, and the continued training that we want to provide to agencies and staff to have that removed from the workplace, because I'm sure that that's also a part of the intersectionality of this is our individual cultures and beliefs kind of flowing into the work that's done or from the community as well. So it's nice to remind us to put that in the basket as we look at this. So I just wanted to add that.
Thank you, Chris. And Dan, you have your hand up, and then after Dan, Dina. So go ahead, Dan.
Yeah, first of all, I wanted to just say, and kind of piggyback a little bit on what Veronica was saying. Some of us have been doing this for a long time. I'm 40 years into this, working in the behavioral health field. And even though we're not at 100% of where we need to be, we're definitely a lot further. I remember being a peer that there were times when I first started out that I wasn't even invited to the table. At least we're being invited to the table. And I think part of that progress, we were invited to the table, but we really weren't allowed to speak. Now we're allowed to speak and they can't shut us up. So I think that's really important as providers and or community members. The other thing is that we need to constantly remember to educate our members on what choices they have. I think that's really important. And part of that will include we as providers need to be trained on what choices they do have. Because a lot of times, I know when I used to be a case manager, I would say, no, we can't do that, and not really have an explanation why. Because really, I didn't know what it was because my supervisors were saying, we can't do that. And so I think that's another piece as we move forward, is really educating the member on what choices they do have. Thank you for allowing me to speak.
Thank you, Dan. Dina, did you want to say something? And then after that, Sean.
Yes, thank you so much. So Nami Flagstaff, we have a peer support group and a family support group that meets every Thursday. And this is free and open to the public, no matter what your diagnosis or non-diagnosis is. And a lot of the times, people who come, they have issues like they need help with medication, they need psychiatric services, and they also need psychological services as well. And we're here to talk about choice in behavioral health. And I usually ask these people, why haven't you seeked out services? Are you trying to seek out services? And the two issues that I encounter basically every single time that I've gone is everything has a wait list. I have to wait 2 to 3 months just to get my intake appointment. And then the other one is no one takes my insurance, so I have to get private pay. And those are, sometimes $100 an hour. So we were talking about choice in behavioral health here in Northern Arizona. For some people, that choice doesn't even exist. There is no choice. It's basically what is open. That's my choice. It doesn't matter if it's a quality service or not. That's what they have to go to. So I think keeping that in mind, that for some people, they don't even have that choice. You know, they're just trying to get help somewhere. And I think the issue is that we do need more providers, and we need more places to accept certain insurance plans that maybe don't pay out as much, but there's an ethical concern of, well, if you're not accepting that insurance plan and everyone else isn't too, then that certain population, I'm speaking specifically about the American Indian Health Plan as well. A lot of places don't accept that because of the low payout rates. It's important that we work on that because these people do not have any choice in behavioral health, and they deserve to have that choice. They don't deserve to only have to go to one place that finally opens up when maybe that's not even a good match. So that's the issue that I've encountered with NAMI.
I would just like to second that. I've run into a wall trying to find over these years what's appropriate for autism, and all the compassion and even talent trying to help people from the professionals doesn't translate if there's no skilled, appropriate types of environments. You can't go to a residential treatment center that excludes your family member's disability. You can't see that 9 out of 10 on the list, if there are 10, don't even accept, or either accept, they won't accept that disability, they have no knowledge of it, and they're accepting it anyway. It's just, there's no choice. And then once they get in somewhere, they're stuck there because there's no stepping down. So I fully agree that choice is so limited up here in the north. And when I've had my son in other areas in the south of the state, in Tucson and sometimes in Phoenix, there definitely were options. Never could connect them up in time before another emergency, never could get through the health home to do it. And so, I know people want people to get well, but it just doesn't seem to come to translate on the ground. Is that really what's going on?
I'm going to jump in then. I won that first pass. Okay. I'm Troy. I'm the forensic program manager for Hope Lives in Flagstaff. And Cher is one of our members. I'm going to let her go first.
Hi, my name is Cher. I happen to be a pregnant, homeless female in Flagstaff, Arizona. So getting the services that are offered are kind of impertinent for me at this moment. Something that I would like to touch on about like the unnoticed populations is when mothers have substance abuse disorders, our solution as of yet, from my perspective anyways, I was dealing with DCS. My daughter got adopted 1.5 years ago. And the solution seemed to be to take the child out of the home. The services that were offered, I don't feel like were actually adequate services offered. I feel like we could have a much better solution to that, like such as like a 2-year program where the mother and child stay in the same facility. The East Coast actually has programs like that. Arizona does have programs like that if you're not involved in DCS, the DCS system yet, but once you're involved with DCS, it's not an option in here in Arizona. And I just think that breaking up that family dynamic is not the solution. Like, I know that I spiraled downhill after my daughter was adopted until just recently when I went to treatment at the guidance center. And then another thing that I would like to touch on is the 911 dispatch being answered by mental health providers. I think that's awesome because a lot of people, I believe, in the community are like reluctant to actually call 911 for emergency services because of the fact that law enforcement is who the responder is going to be if you call 911. And if it's not the case, then I think people will actually be willing to call 911 in a lot more situations. And I know Paul said that the percentage for arrests for Native Americans was 50%. What's the percentage for like the drug related arrest? Do you know that?
I don't know that offhand, but much of that is either directly or indirectly related to substance use.
Right.
Yeah.
Right, I would have to agree. That's why I think that also the 911 dispatch being answered by mental health providers can actually connect them to the medical services that they need versus the criminal justice system. Like, I'm actually going to be starting recovery court here in April, which is a blessing. Like, I am very grateful that that's an option versus being part of criminal court for my mistakes that I have made. That, you know what I mean? I'm in the process of being rehabilitated so that that is no longer an issue for myself. I think that's about all that I have to say.
Thank you. Okay, Mayor, do you see, and also Dina touched on this. So Hope Lives, we do a lot of work with our justice involved members. We go into the jails and do pre-release planning. We pick them up, take them to treatment, after treatment, bring them back, and just help them in all the ways that we can, like connecting them to their PO, to get them to court, getting an ID, right. So we're doing this all the time. Right. One of the things that I've noticed is that for our justice involved members, most of them are not currently enrolled in services at the time of arrest. And many of them get sent to out of county for treatment or to jail or whatever. So it can be a huge problem trying to find a payer before we go pick them up from treatment and bring them to a court date. I just got an email this morning from the public defender's office saying, I have a person who's in Phoenix at the Phoenix Rescue Mission, and they have a court appearance up here in a couple months. What can we do? And I said, we'll figure it out. But I got to tell you, there's so many individual cases because, you know, they may have charged in different counties or they may live, or I don't know. There's just so many with the justice involved members. There's so many points to connect that it's difficult to find a payer. And it makes it difficult for us who are treating them to bill for it. I spend most of my time figuring out a way, finding out how to get a referral for this person.
And
Good.
May I?
Yes.
So like with Hope Lives, it's they've been continuously willing to be supportive. Like, even say I make a mistake and I get kicked out of another service that I'm being offered at the moment, which during substance abuse disorders, that's going to happen with people. Like, I'm not the only person that's had a lapse or relapse throughout my recovery program. And I'm still interested in my recovery program, but get kicked out of a service that I was being offered. And like, good thing about Hope Lives is that they don't just drop you from their program because you made a mistake or you didn't follow a rule that in that case got you kicked out, even if it's a simple rule like missing curfew or something, you get kicked out of your halfway house that you're living in. Hope Lives is still continuing to support me and make sure that I'm getting the next service offered if I do mess up or not align with the services being offered at the moment, which I am really grateful for Hope Lives for that reason.
This is Jane Cowell from Family Involvement Center. I'd like to kind of circle back really to the topic of choices and some of the things that Dan said and a couple of the individuals that were talking around autism and things, that topic. When you are looking at with children, parents do not have, the choices aren't clear to them because they don't know the background of how children can receive services and how common this is. They feel like they're alone. And when I think about choices, I think kind of Dan kind of went in this circle too. They have to know more about how the system works, and they need to be able to find to pick things, but they won't know what their choices are until we help in our systems of care educate more so that families will seek services earlier. And a lot of times that is going to happen in informal situations or through the family runs or the peer runs that do education for parents and things like that. And because I don't think you can say that they really know their choices out there, because we haven't really looked at it from this projection of a family sitting there with kids with multiple problems. Maybe mom has challenges too. And until we, and I'm not, we've come millions of miles and activities over the last 20 years in the children's systems reform, but it is, and we work primarily with children and their parents. And what we see is they had no idea there was this out there. They had no idea. And when they did get enrolled someplace, they really didn't get, they didn't have enough knowledge to be able to even ask for what they needed. And so when I think the choices, we have to, I think, in our communities, Nami does a lot in this area. We do some, my kid, others, and I know that the peer runs do too. And that is, you can't solve this thing with choices unless we also are really taking a deep dive to help individuals that are raising children, because the chances of their overcoming and their resiliency drops so fast when they are growing up and not understanding. The child themselves is not understanding what's different. And we have parents who are afraid to get these services and things because of what will happen with their school or all those things. So I'm just making that plug there, that we have a lot to do to to improve in our communities across the state. We've come a long way, but I know there's still a lot more we could do. Thank you.
One of the things that we're always talking about at Spectrum is system design drives service delivery. And a lot of what we've been talking about, or that I've been hearing today, is us talking about just that, the way that the system is currently designed. And I agree with everything that's been said in terms of the downside of the subcapitated model, the health home model, and how that has imposed, on the one hand, some restrictions in terms of choice and available services and so forth. Back in 2018, when we went from that single payer system in the north, the single REBA system, to including 2 health plans, it allowed us to dip our toe into the fee-for-service world, which, I'll be honest, I think all of the providers of service were a little nervous about that, right? Because rather than being able to count on that regular influx of cash on a monthly basis that we get under the subcapitated model, now we were going to have to potentially be looking at 90 or whatever amount of days it takes for a turnaround on a fee-for-service payment, so we can keep people employed, so that we can keep providing services, so we can essentially keep the wheels on the bus. And I, for one, feel very optimistic for the future in terms of where I hope and believe things are going. I think a fee-for-service model does allow for greater choice and greater opportunity. And I think that we saw that as we've entered into that world once that big change took place in 2018. Another thing that makes me feel hopeful, believe it or not, is what's occurred during the pandemic. The COVID-19 pandemic has opened up worlds and services to us that were not previously available. And I'd like to start with just the availability of telehealth. And not only the availability of it, but the acceptance of it, both from the provider side and from the recipient of services side. Prior to that, we were offering, as I know a lot of other providers were offering telehealth services, but it wasn't used that often. And the pandemic sort of forced us all to get more comfortable with it. And on the heels of that, then, we have been able to bring in more service providers. I have been able to be a little bit more choosy about the therapists that we bring into the organizations. And a lot of those folks that are able to do work from out of state, we have providers from all over, whether it's nurse practitioners, psychiatry, therapists who are frankly, highly trained, skilled people who saw an opportunity to work from home or to provide services from wherever. That is super exciting stuff and offers us an opportunity for better service delivery that I think we've never had before. Along the same lines, I hear the autism piece, 100% absolutely right. And now, not only can we contract and partner with individual service providers who may not live in the northern geographic region, we can go outside of this area and contract and partner directly with providers that specialize in autism services. And, Spectrum, that's another area that we've got a new relationship with Devereaux that specializes in that area. And we're opening the door and starting to do some things there. So that's my spiel. Like I said, I think there's a lot of reason to be optimistic and to be better at more options and better choices for everyone we serve.
Thank you, Sean. And I wanted to first just jump in and thank Sherilyn for telling the story, your experience. These are the things that people really need to hear to create the cultural shift that is needed, that is underlying all of these issues, from the bureaucracy to funding to choice. That's what it comes down to. And to bounce a little bit off of what Jane had mentioned about the education and the need for people to understand, to create that early intervention, that it's critical for parents in particular. And, something that I don't think I've ever spoken about publicly, but I was diagnosed bipolar at 15 years old. But I came from an affluent family, 2 doctors who recognized the signs, who understood that I needed assistance right away and was able to get it. And one of the biggest things for me when I look on the street and see folks who are clearly dealing with substance use issues, clearly dealing with, hallucinations and so forth, I just look at them and be like, that could have been me if I was born under different circumstances. And you know what? If that individual would have been born under my circumstances, they could be the mayor of Flagstaff. And that is something that is so critical, that we educate folks and to really, bring it back here again with the policies, the funding. These stories need to be out, and individuals who are among the influencers, and whether that's in the political landscape, within, honestly, the entertainment landscape of musicians or anything else, we have to create a cultural shift. And that is fundamental to all the things we're talking about, to create the choice, to get people interested in those professions, which are understaffed, for counselors, to understand that, people who are suffering from mental illness or substance use, that then get help, realize, what, your experience can truly help others, not just from telling the stories, but also entering the workforce in this manner to create the connections that are needed. And I just want to really just kind of point that out, that what we inevitably need is a cultural shift in understanding. And to bounce off of what Sean mentioned, actually COVID, the situations we're facing have actually provided a certain opportunity to that, because to a larger swath of the population now, we understand what isolation feels like. We understand what the struggle feels like, stuck in our heads, what many people who are facing, drinking issues now because of the pandemic, that I think that there is an opportunity for a great awakening. And I just want to promote those to provide their experiences, to explain the situations that have occurred. And through that process, creates a ripple effect to service provision, bureaucracy, to the choices people need to get better. So, yeah, thank you.
Anyway, I just would like to add a comment to what Mayor DC has just talked about. What I see is with children's system, this change in how we work with families of children has to change, I believe. It has to happen before they get enrolled in treatment. They don't know how to go, look for those services and things. There has to be education, and it's if they can't, and in a positive way, that there is help out there, but we have to treat the families. The 9-year-olds don't go seek help, 14-year-olds don't go seek help. We have to help the parents. And that I think has to be more of a prevention or community education. And that's why I wanted to respond to Mayor DC's comments, because that is our community. And if we can help communities understand that the children with these challenges that they see in schools and in the community, that if there were more education for the parents and examples brought to the attention of the community, I think we could, that's a part of what we would need to do to change the culture of how children are seen and how their families need to be supported early on. And thank you for the time.
% agree with what you're saying about educating the families about how to care and how to request services, and really giving them those tools to say, you can self-refer yourself to an agency, and then you can turn back to your provider and say, okay, now it's up to you to send the supporting documentation. But families 100% have that right to call and schedule intakes or appointments, but they're not aware because they get told by providers, we have to do it our way. And I think you're right, starting to really educate them and putting that power back to these families raising these kids with special needs is a crucial part of how we're going to open up the system for them a little bit more.
Thank you. I agree.
This is Kathy Basher. We have had a wonderful discussion, and I'd like to shift it just a little bit. And what kind of did that was Paul's comments. Some of us have worked in the system for many years, and we've been very effective in Southern and Maricopa County. We understand the value of people speaking out, sharing their stories, but it's been very difficult up here. And, we have celebrated, it's not that they already didn't do a good job, it's just that we needed change. And one of the changes was we had to have choice, and we needed to have strong peer and family runs up here. And what we were not getting is referrals to the peer and family runs. So they really could change that culture. And so that is part of the reason of the dialogue today, is to talk about how we could change that culture, how we could open up the avenues for people to share their stories. All this is the way to change the culture, but it's a very strong culture up here. And I just wanted to point out, we sent a one-pager to everyone, and I'd like to discuss it a little bit, have you guys share a discussion on this, because there's been legal mandates from the feds all the way down about choice, and yet that has not manifested itself in this area for quite some time. And I know peer and family members have struggled. We've struggled to get data. We've worked with Susan Kennard to do one-pagers, and those are all about the rights of people and to get into the clinics and train people. And it's been a very slow process. And so I would you guys have all received this, it's called Member Choice, Arizona Medicaid System Requirements. And Susan, you might jump in here because we now have a new REBA. They've said that they're going to open it up for a referral for 90 days instead of 10 days. That's been a major barrier. Our request is, can you open it up now? You have to wait. Okay, can we start moving forward to change some of that culture that's been there? And it's going to be very, very stubborn. So the things that Paul was talking about is the dream that we're all waiting for and working very hard to establish up there. So I guess my question really is, we know the feds have mandated it. The mandates have come down to Access, who really has not provided much oversight. It's gone to the REBA. The REBA has structured a system where we can't track and keep adherence to the whole concept of choice. So I'd like to just kind of open that up for further discussion.
Kathy, I'll jump in really quick. And just to say, you know, I think for us, we've tried to build those, and we have built those partnerships. So for example, NASCARE, they are the peer provider at our crisis stabilization unit and at our hospital. And, you know, Greg and I have had conversations at times when things haven't been working very well. And it always comes down to that communication that you're talking about and that education and what's happening in each other's centers and systems. So, you know, I don't think it's about will. I think, you know, we talked earlier about some of the minutia of just the system and how it's easy to get caught up in that. But we also this past year developed a really great partnership with Family Involvement Center. And we're trying to kind of model the Cradles to Crayons in Maricopa County up here. And so our teams meet every single week, and we have family involvement specialists involved in every team. So, you know, I think we're really trying to break down some of those barriers while balancing, you know, that we too have peer programs, and there's some value in that for some clients, but how do we strategically, as Sean talked about and I wrote it down, Sean, system design drives delivery, right? So where is it that we have our partners, our peer-run organizations in our system, so it just naturally drives that? And, you know, when we think of some of those most vulnerable places like the crisis stabilization unit or Windhaven, and having NASCARE there, it's a game changer. It's a game changer. NASCARE gets connected with people. They develop those relationships. They have that opportunity then or the client gets that information right then, right? Like you have this choice, and here's this great partner that you have been working with during the time that you've been in the facility. So I think it's, where are those other opportunities that we can design the system to deliver the service that way, right? And it just makes it really natural. And because for us, that also just removes some of the red tape and the barrier, candidly. And it shouldn't be that way. But again, we know people do well, and we get the best outcomes when there's team and integrated care, team-based care and integrated care, and peers are a part of that everywhere in our system. So how do we grow and expand that?
Just asking, so the providers that do the initial, what is it called, intake, do the plan, are the ones that actually deliver the service. This is inherently a conflict of interest. And within Altex, they've understood that, and they've separated the two. So is this a problem for the providers, or could you elaborate a little bit more on what we might change within the system to make it, you know, to keep the specialty providers and get the referrals?
Yeah, I can offer one example. This is Dan Davidson. I'm with KaiBad Behavioral Services, and I would like to share a little bit about our services, not as the best option, but a different option. We're talking about choice here. We're talking about choice for individuals to choose their providers and their services. If there isn't a lot of variability within those services, or if people don't know what the strengths are among different services, then it's really not a choice. Similarly, I've been a part of a lot of wraparound planning and person-centered planning over my career. And when people are given this choice, finally, because something brought them to everybody's attention, often in my case, it was behavior that got out of the way and this person was really at risk. So now we bring services to bear. When we give people choices and they don't know what each option is going to feel like, then we have an incomplete system. So we're a specialty service, and we are part of those service plans. A health home refers to us for specific services. In our case, our services are behavior analytic. And some of you may think of ABA or behavior analysis in a bad way because there's been some press over the years. But let me just describe what we do. Our mission is to help people live quality lives by teaching functional life skills that increase their access to positive experiences. So without having joy in your life, you're not going to be doing well. So what that means is we serve people with all kinds of abilities, disabilities, age, whatever. Often we get people who have challenging behavior, whether it's self-harm, whether it's harming others, whether it's property destruction, whatever. But people use challenging behavior only because it meets a need. Somehow, some way, it meets a need. Nobody's going to persist unless there is some need that's getting met. They do so because they either lack more appropriate alternative skills to get that same need met, or they lack the motivation to use those skills in certain difficult situations. So our approach is to identify the skills that are missing, teach those skills, motivate them to use those skills in those situations where they're most needed. We focus on serving the person where they are in their own home, either in person or telehealth, or in their school, or in their job, or in their wherever the challenging situations are. In Northern Arizona, we focus on Northern Arizona. If the person is far away, we'll definitely rely and try to do as much as we can with telehealth.
Daryl, I have two questions for you. One, do you get many referrals from providers? And two, do you have peer and family members sitting on your board?
We don't have a board. And do we get referrals from whom? I'm sorry.
To the provider. You don't have a board? Do you have, I guess this is one of the questions that I wanted to throw out to everyone. One of the ways providers and the REBA can start helping us is to put peer and family members on your boards as a true voting member, not just, a token. And, Cheryl, if I'm saying your name right, we need more people like her in speaking. Why aren't we invited to conferences and participating on what's going up at here? I'm a peer. I spent 7 years in mental hospitals, including the state hospital, and yet I have so much to offer, and I get very, very little invitation to participate in issues up there in Northern Arizona with my knowledge. Why is that? Why aren't we invited to participate in what's happening up there? We've got Deb Jorgensen, and Veronica, that have been leaders up here and have done a stellar job, but they need to be out there speaking and presenting and being posed as leaders. And so we need you guys to back these people to be able to do their job. And I'm just throwing this out, but these are ways that all of us can work together as a community to make this happen.
Yes, so I actually, outside of Nami Flagstaff, I work under Dan Davidson. I am the billing and operations specialist for KaiBab. And of course, I'm not a decision maker for them, but I can say, I think it's a part of it is that KaiBab is a very small business. And the issue now is to tend to the referrals that we get, because as we all discuss, we have so limited providers. We have so limited choice. So right now, the priority is that we attend to those referrals that we're getting But I think what you're saying is very important. And I feel like that's definitely something that we can work on. Because as you know, NAMI is all peer and family member run. So there's definitely room for NAMI and places like NAMI, like NASCAF, for us to collaborate with providers. And I think that that's a really good idea. And that's something that's going to take a lot of community involvement and input from the public as well. So I think that the point that you're making is extremely valid, that we deserve a voice with providers as well.
I was just going to say, you know, in my perception, I do believe that in the northern region, we do have strong and robust peer and family run organizations. But what I do also think is that there's a lack of abundance. We need more. It's a very large territory and it's largely underserved. So I would not agree that it would be the strong and robust of the agency. There's a lack of. We need more. There's so much community with minimal providers and partners. You know, and we provide the training, we look at the training, we get early intervention and prevention, and we look at the system and the red tape. And over the years, the system has really opened themselves up to really look inside themselves to see what changes. But I think within this topic too, it's going to be very hard not to address the elephant in the room. And in my opinion, you know, along with the other changes, we need to go back to community stigma, bias, and tasking to our own self agenda, that culturally welcoming environment to provide informed choice and voice. Sometimes there may be territory. We need to look inside those communities and take a look at the cultural aspect. So it's not a complaint and it's not a crying session. But if we're going to talk about the issue, I think that we really need to talk about the elephant in the room and a lot of the elephants. It may be a herd. So I just kind of want to throw that in there because it's a big part of making change. Because if we can do all the work, but it means nothing if we can't make stigma and cultural bias change within communities and providers. It's both.
Chris, thank you so much for saying that. And I think some of it for me comes from practicing curiosity, right? So, you know, Kathy, I haven't had the pleasure of meeting you. Part of it's I haven't been here in Arizona very long, and then most of that has been in a pandemic. At the same time, I will say, you know, we are so fortunate to have Katie Welty, and who speaks on stigma. Every single employee that gets hired at our organization has a training with Katie around stigma. That, Chris, to your point, it really challenges us as providers to really look at our own compassion fatigue, how that leads to stigmatization in our system. It is one of the most powerful trainings, I think, what we do as part of new employee orientation. And then Katie is a strong advocate all the time. So, you know, I think some of it's practicing curiosity. It might not look the way that it does down in southern and central Arizona. And again, I'm very ignorant around that because I'm still learning the system. I totally own that. But I think that there are some really cool things happening that we also need to get curious about, right? So we also have a partner advisory council, and they are not some token committee. They are not. They help us design our services and our system. I go to them with problems. As a CEO, Katie and I meet with them on a monthly basis, and I go to them and I'm saying, this isn't working out. Tell us how we can do it better. We practice the I hope, I wish, I wonder, right? Or I like, I wish, I wonder, that human design in that committee, where it is people who receive services from us helping to shape it. They are very candid about some challenges that they have been having around our med services, right? But they have also said, this is what we need. And then that gives us the opportunity to go and work on that. And I'm accountable back to them. And I go to them and I say, this is what we've done based on the feedback. So it's not exactly what you're talking about. And there is so much room to grow. And I appreciate the dialogue. But I think it's really helpful when we practice curiosity about what we are doing. And I think, Kathy, you asked earlier, how do we build off of that, right? So it's great, Polara, that you have NASCARE coming in to do the groups at CSU and Windhaven. Where are those other opportunities to do that? And what does that start to look like? So I think the conversation is so important, but I couldn't not share some of those things that we're trying to do, and how blessed I feel to have Katie as a colleague of mine, and to have the Partner Advisory Council. It is the number one thing I do every single month, is my 2 hours that I spend with them. So thank you for letting me share that.
This is Deb Jorgensen, and I wanted to share very quickly that Jane and I have had multiple discussions about this, and it is preventative care versus crisis-driven care. I think that we've been shaped to respond to that crisis and not really hear that pre-crisis voice as much, and respond to that as much, because for many reasons, it could be limited resources, it can be a lot of different reasons, but honestly, it's become a culture. And it really strikes me as a peer myself, and hearing, I was in treatment when I was pregnant as well. And so, my Chair, your stuff hit me hard. And Paul, having that diagnosis early and having access to care that was quality, because of economics, it makes a world of difference. It makes a world of difference. And if we are able to put some prevention dollars on the table and allow our peer runs and our family runs out there to, to be doing this education and be paid for it, would be amazing. That would really help, for one. I just wanted to also share that Dee had to leave at 2 and drop off for another meeting that she had, but she's the first phone call I make when a family contacts me or a member contacts me. That's who my go-to. If someone contacts me from Health Choice, my first call is to Veronica, and we, and it's a warm handoff. But people don't know that OIFA is out there and the door is open. So that's another message we need to get out. And Susan, I cut you off. I'm sorry. Go ahead.
That's okay, Deb. I was just going to put a plug in for OIFA as well, with all of the talk about how important it is to bring in community voice and that peer and family voice. That's exactly what the OIFA departments do at Access and at the health plans. I was just talking to one of the OIFA leads at another health plan this morning, who was so excited by some of the community opportunities they had to hear the voice directly from the members, what the member needed and how that is making changes within their health plan. And that's exactly what we want to see, and that should be driving those changes. So the work that we are all doing on this panel today is just so incredibly important. And I don't know what you do with this, Lori and Kathy, to kind of keep the conversations going afterwards and creating some next steps. But I was writing down so much of what people were saying. We need more education, prevention, resources, making sure that the network is sufficient, crisis intervention. Thank you so much for that change that's going to be happening in Flagstaff. When you talked about that calling 911, I have the experience of dialing 911 myself and having my loved one who lives with a serious mental illness arrested and put in jail when he was in a psychiatric crisis. So thank you for doing that. That would make me feel comfortable calling 911 again if I needed to. And also, I just wanted to touch on something that Cricket said that just touched my heart so much about being a parent. I don't like to admit I'm getting older, but I definitely am. And I want to make sure that things are in place so that when I'm not able to help my son anymore, right now he is once again got notice he's going to get evicted because he didn't pass his inspection. And I'm like, so who's going to help when I'm not here anymore to step in for these kinds of things so he doesn't end up homeless.
This has been a wonderful discussion, and I'm going to let Lori kind of wrap things up. But, you know, I kind of have a different feeling about the community. I feel like I might belong a little bit. I know some of the leaders going on up here. It was a big move for me to come up here. And, you know, we haven't talked about the positive things and the things that have really been accomplished and what we can capitalize on as we move forward. And so I really want to encourage everyone to keep that in mind. It has been kind of ugly. We've had to rattle some cages and it's been bloody, and we knew it was going to be bloody. And people have been hurt and in the process. And so now we need to reach out and kind of bring the community together. And that's part of this dialogue to do exactly that. So you guys are leaders. You're the ones that can facilitate change and ensure that it happens and take some of the messages back. We can hold care first, feet to the ground as we move forward, that, you know, there's certain things that we want. And so at this point, and again, I really want to thank you. You know, there's some people here that I haven't seen for a long time or I haven't met, and you guys are really pretty cool. We got a neat group up here. So I'm going to turn it over to Lori and let her wrap it up and put a big pink bow around it.
Yeah, I think that we've got a real powerhouse. And when we look at next steps and where do we go from here, everyone on the panel has email from some of the notifications I sent to all of you. I hope that you connect with each other going forward, and that, you know, this is like we dropped a pebble or thrown a stone into the pond, and now the ripples are going out, and each of you connect with each other, or several of you together. Obviously, you know, prevention, education, resources, these are crucial things. And we know that the more that is spent on the front end saves money on the back end. If you can prevent that person from going into Windhaven or any inpatient facility, you're saving more money. But aside from that, you're helping the quality of that person's life. And that's what we're all here for. The people that we serve, the people that are coming in for the services. So to ensure that they have choice, and it's become evident here, a lot of people don't know what the Medicaid system requirements are. They don't know what the choices they have are, and how to promote more education, provide it so that people have more knowledge about these things. The ability to do self-referrals for the peer runs is huge. And I think that's going to increase the capacity. And I like Chris saying we need more. We need more choice. You don't want to saturate in a small community, but there's diversity in what peer runs do, and bringing more in. Everyone has agreed that there are more people needing services than the system is able to provide. So let's open those doors. Let's all talk with each other. Nobody is a threat to anybody. We're in it together. And I just want to thank everyone so much again for being here.
Especially Candy and Christina. Stick your head out here. That's Candy.
I can't even get in her back yet. No.
Come on, Candy.
Candy's office is where we do this.
Yes.
Control of the camera.
Isabella,
There's Candy.
oh, if you can show your face, Christina.
If she turns on her camera, she can.
Okay, so
Christina.
and she was helpful.
There she
you
is.
are.
Thank you, Christina. Yeah. And, you know, and I hear requests to do more dialogues. Yes, they are important. It's worth every bit of time and collaborating and coordinating to put it together. Another thing I want to promote is OIFA, Office of Individual Family Affairs. A lot of case managers in the health clinics have never heard of OIFA. Here's an educational piece. A lot of people haven't heard of the Arizona Peer or the Northern Arizona Peer and Family Coalition. You know, it shouldn't be a secret. It should be out there for people receiving services to know and utilize, providers and recipients as well. So I just want to thank everybody for what you do.
I just wanted to add, this is being recorded and it will be on Nami Yavapai's YouTube channel.
And
Probably
also we're
by
developing videos and maybe, Shayna, what is it? She would like to.
Sherman, yes.
Yeah, let us get contact. We'd like you to help develop a video, Sherilyn.
So I put that in the chat. Anybody can reach Nami Yavapai at namiyavapai.org. So if you want to get in contact with us, or info@napfc.org. There you go.
All right. So thank you all so much. Pat yourselves on the back for what you're doing and give everybody a group hug.
I agree. Thank you.